Hello, everyone. A very good afternoon to all of you. I hope your Sunday is going good, and we are here to make it better. Today, for those who are joining for the first time, today is the first day of DRDCA 2020 1 month long virtual conference. And I, Dr. Pallavi Mahajan, am your host for all the scientific sessions. I did my post graduation in 2016 in conservative dentistry and endodontics from GDCRI Bangalore. And since then, I'm practicing as a consultant endo in various clinics. I'm also a spoken word artist, details of which I'll share with you slowly and steadily over the sessions. Coming back to scientific sessions, we at DRDCA 2020 have scheduled scientific sessions for the month of November every Thursday, Saturday, and Sunday. On weekends, the sessions, there will be two sessions, one morning and one evening session. And on Thursdays, there will be just one evening session. For those who did not attend the morning session, today we had in the morning session Dr. Sigal Jacobson, who joined us from Australia. She's an aesthetic dentist and she's the founder of a unique template system called UVeneer. The whole session is there on YouTube as well as FB page for you to see. My preference will not be YouTube or FB, but app. The app which is the utmost requirement for you to download if you want to attain all the benefits of this conference. You have to download the app, register yourself, and then what you get is 40 CD points. You get a certificate, and yes, lots of knowledge, which anyways you can acquire through YouTube and Facebook. The lecture, one more thing that is there is the lucky draw competition, Novalace. This one, right? So the details I'll be sharing after this session. But yes, one prerequisite is there, and that is to download the app. You can put all the questions in the comment box, and we'll be taking this question and answer post the session gets over. The speaker who's joining us now is a big name. According to him, we are not just tooth doctors. Well, that line in itself is poetry for me, to be honest. हम दांत से आगे भी बहुत कुछ हैं, right? So, Dr. Rajesh Raveendranathan. Dr. Raj, who's a neuromuscular dentist. Dr. Raj is founder and president of ICMO India section and secretary of ICMO International. ICMO is International College of Craniomandibular Orthopedics. He firmly believes, as I said, that the dentists are not just tooth doctors. Dr. Raj did his BDS from Chennai, India. He has done his PhD from France, diploma in neuromuscular orthodontics from Italy, diploma in dental sleep medicine from USA, diplomat in orthodontics Spain. He's member of International Functional Orthodontics Association. Dr. Raj has his own brand. The brand's name is Right Bite Craniofacial Pain Care. The centers of which run across the South Asia to treat patients with craniofacial pain and sleep disorders. In India, the centers are in Bangalore, Delhi, Mumbai, Kolkata, Trivandrum, and Mancheri. In the lecture, Dr. Raj is going to explain how the principles of neuromuscular dentistry can help us not only to remove patient's pain, but also to avoid it by incorporating them in the procedures we perform. It often happens actually that a person visits us, we give a restoration, and when the patient goes back, after 2 or 3 days, we get a call that, okay, I am having pain in the tooth, which was earlier asymptomatic. So what we do, we call the patient, we grind the tooth, we do this, we do that, and then the impression and everything goes bad, right? So what is needed is to know the anatomy and to know that part, that dentistry prior, so that we can incorporate it in our while doing the procedure itself. He is also going to speak about sports dentistry. So without wasting any more time, as I said, question and answer session, just keep posting your questions, and question and answer session will be there post this session, 15 or 20 minutes as per the questions. I welcome Dr. Raj and request all of you now to pay attention and save your questions. Dr. Raj, screen is yours. Hello, Dr.
Hi.
Raj.
Thank you, Pallavi,
Thank
for
you
that
so
wonderful intro. Thank you so much. First of all, congratulations to Dental Reach and the team uh, under Dr. Roxon for doing this wonderful job of having such a uh, spectacular show online. I never knew this could happen, but as you can see, I'm part of it now, and I'm proud to be here. Uh, Today, I'll be talking to you about sports dentistry. I like how Dr. Pal, I'm mainly into TMJ disorders and craniofacial pain and sleep medicine. That's what I normally do. But then there's something that I came across where you can apply the science of neuromuscular dentistry, and that's sports medicine, improving uh, someone's, actually anyone's athletic performance. It's not a drug which can be legalized or anything like that. It's just something that you wear in the mouth that will help you improve the balance. Like people wear foot orthotics, we now give patients mouth guards. Uh, Unlike the normal mouth guards you buy off the shelf in a store, you need to give them customized mouth guards, and these are known as sports guards. I've come up with my own sports guard. It's known as the Right Bite Sports Guard. So we call it the RBS Guard. We have a lab in Bangalore that makes it on the specific bite that we provide the lab. And that's what I'm going to be talking about. What's so special about the bite, right? Okay, so I'm going to share my screen. Oh, it's already shared, right? Okay. Am I good, Dr. Pallavi? Can I go ahead?
Yes, sir. Screen is very much clear. We can see. You can go ahead.
Great. Thank you. So that's what I'm doing today, and that's my organization. We have I'm the chairman of the Right Bite Craniofacial Pain Care, along with my two partners, Dr. Girish in Bangalore and Dr. Abhimanyu in Delhi. We have currently 3 centers, and we are opening up centers across the world, hopefully in a couple of years' time. And the other company is we Indra Craniofacial Pain Relief is all about being a distributor for equipments that are not available in India with regards to neuromuscular dentistry, specific TENS units, and ESG sonographs, as well as kinesiology devices, things that are not available in India as much. So that's why we got into it. And those are our centers currently. I'm a visiting consultant in Calcutta and Trivandrum, and the rest are ours. So, like I said, I've been visiting my Delhi office for the past 6 years, and slowly but surely we came in touch with a few physiotherapists who were, on board with different teams, professional teams. There was a cricket team and there was a football team, uh, to be precise, who were involved. And these guys came up telling their players were getting injured too often, and they knew that there's something about a mouth guard. And that's what even I started thinking about it. My first exposure to the whole thing was way back in 2010 when I was at a conference in the US. I heard Dr. Anil Makar, who had come up with the uh, pure pure mouth guard, pure power mouth guard (PPM), and I knew that there's something like this, but I just never got into it because I never had the time. I was mainly into pain, I'm relieving pain. So that's when this thing happened. So when they came forward, so most of these guys, most of the physiotherapists, what they kept telling was uh, after their day session or their game or their training, They come back with injuries, mainly back pains and foot injuries, and the knee is another prone zone where these guys get injured. So uh, they work them up and they're fine by the evening till the next day morning. They again go play. Evening, it's the same thing again. Uh, so the reason is they knew that there is something that's not holding the work that they've done, the whole posture. It's not holding in place. So that's how they got to know about these mouth guards, pure power mouth guards to be precise. But that's not what we do. So they came over, and now we have in concordance with the physiotherapist, we create these specific mouth guards, and we work on them. We adjust them with the help of a mat scan, as you can see down here. Uh, that helps in uh, measuring the sway patterns, measuring the weight distribution in every even a fraction of an inch. So it's that precise, and that's how different our mouth guards, and most of these guys are now wearing it. We have uh, four guys on the Indian cricket team. I can't name them, sorry. We have three superstars in badminton. We have two tennis guys wearing it. We have an entire football team on the ISL that wears them. So it's helping Indian sport come up as well. So let's talk about what it does. First of all, neuromuscular dentistry. I came up when I came to India in 2006 with the science. No one even knew about this, and I was kind of flabbergasted and kind of excited because uh, obviously no one knows anything about it. So it was a big challenge to me, and creating an awareness on the subject was my first challenge. So obviously I've been lecturing since then in almost every state, every venue that I get invited to. But the sad thing is, I'm still talking about, the introduction to neuromuscular, because there are still thousands and lakhs of dentists who don't know what this is. Uh, Dentists are so prone to just looking at teeth, I that they forget that there are other things that are attached to the teeth. Every work that they do, from something as minute as a filling all the way to multi-implant supported processes, occlusion plays a role. The jaw position plays a role. Anything that changes occlusion would change the position of the jaw. Anything that changes the position of the jaw, in turn, is going to change the posture. And that's what I'm going to be talking about today. Okay. Uh, I don't know how many of you guys have seen my lectures, but just as an example, I show these two cases every time I go anywhere. So you can see this man on the left. This is when he came to us. He had been diagnosed with trigeminal neuralgia. The reason why I do that, because it's all about the diagnosis. I believe he was not diagnosed correctly. He couldn't talk. He had lost his job. I just asked for his name. He couldn't even say that. And look what happened in 2 weeks after wearing an orthotic. Is normal. We did not do anything for the trigeminal neuralgia specifically, because it was not trigeminal neuralgia. It's all about the diagnosis. All he had was a simple craniomandibular pain, right? I wouldn't even call it TMD. So it's all about those names and uh, nomenclature that we provide. This lady here had come to us all the way from Austria. Every time you can see how her body is vibrating. Every time she tried to stand straight, her body vibrates. So all that started after she had a filling done. Think about that. She could feel the high point, and she went to a lot of dentists to get that high point cleared, but they just never understood the relationship. She found us online and she came to us.
So
all
we've
we
just
did was we didn't even
created
give her an orthotic. We just shot the bite
neurocentric bite,
and we put her on
and
the
she's
bike
been on for like
with
10
just
minutes.
2 pieces of putty.
Can you
And
just bend down and
5 minutes,
feel
she
your
was
feet?
asked to walk up and
Touch your
down.
feet?
And look at her standing
Oh,
straight, touching her
wow.
toes,
Great.
and no jerking whatsoever.
That is great.
And that's all we did. Just
Okay.
got her
Put it back
onto
in.
the right bite.
Awesome.
And hence the name of my center is the right bite. uh, I'll be talking about all these diagnoses. For example, Florence Nightingale, she was diagnosed with fibromyalgia. So was Paula Abdul, Morgan Freeman, the more famous Lady Gaga, and our very own Salman Khan. I've heard that he suffers from trigeminal neuralgia. He's undergone a couple of surgeries and yet still he is in pain. Who knows? He might be having just TND, right? So I'm waiting for him to walk my door once I open my center in Mumbai. Okay. So fibromyalgia, cluster headaches, musculoskeletal pain syndrome, tension migraine, blah, blah, blah. Vague but complicated diagnostic terms. All these terms are created when the doctor doesn't know what the problem is. Or finally, they would just call them idiopathic, right? We would have heard a lot about that. But the minute you call something idiopathic, you should understand that, nah, you are wrong somewhere because it's not idiopathic. If there is a problem, there is a cause, period. It's up to the doctor, who has to be a good diagnostician as well, to discover that cause. Okay. So, can we dentists treat these cases? They're all simple neuromuscular disorders that have gone undiagnosed, most of them due to a simple bad bite. Bad bite leads to weak muscle that leads to postural imbalance. How do we fix it? Well, I do this by incorporating the principles of NMD in everything that we dentists do. Like I said, from a single tooth filling to multiple implant, full mouth rehab. So just make sure that the bite is perfect. Make sure that the muscles and the associated structures are perfect, are in harmony with each other. You can't get them perfect, but they need to be in harmony with each other. He's the known as the father of NMD, Dr. Bernard Jankelson. All the way back in the 60s, he came up with the science. And ever since we've been virtually fighting the general perception that dentists should just do teeth. Like, the movie Hangover, right? Stu gets really screwed by Phil. You're just a dentist, you're not even a doctor. But we are much more than that. And we have created that for ourselves, frankly speaking. So, what is his motto? If it has been measured, it's a fact. If it's not been measured, it's just an opinion. Okay. So, all that neuromuscular dentistry does is measure. People ask for proof, research papers, studies. Frankly, I don't have the time for all of that because I'm helping my patients get off their pain. Uh, and every step of our treatment protocol is measured. We measure the EMGs, we measure the position, we up to a fraction of a millimeter. Everything is measured. So I don't know why people still question it. Doesn't matter. Uh, the primary aim of NMD is to keep the stomatognathic system happy, which involves the four systems, the muscles, the joints, the teeth, and the airway. We just had a conference 2 weeks ago by our organization, ICMO, International College for Craniomandibular Orthopedics. It's the only organization in the world to support neuromuscular dentistry. We are pretty strong. We've got 1,000 members across the world. And in India, we've started the India section 3 years ago. We've done 2 conferences already. The the just concluded conference was on airway. We had 17 speakers from across the world who were talking about that, and it was amazing. We had 200 plus guys who were there. So, in the stomatognathic system, the teeth are the most dominant. Why? Because the teeth decide where the jaw should end. So, the teeth go this way, the jaw goes that way. If the teeth go this way, the jaw goes that way. So, finally, that's where we need to be thinking more tooth centric. But keeping in mind the joints, the airway, and the muscles. Because if there is a problem in the teeth, the other three are going to accommodate. No matter how malpositioned the teeth are, the muscles will struggle to create a centric occlusion. So that's what we've been learning all the while, centric occlusion. A centric occlusion can be wrong too, because if it's habitual, the bite is like this. I'll show you the next figure actually. So do you see these two people here? Look at this guy. Look at his right bicep and look at his left bicep. There's hardly anything here. What could be the reason? He could be lifting weights with just the right arm. He could be using just the right arm, building up that muscle. The more you use a muscle, the more that muscle develops. Same thing with the face. This patient could be, missing a left tooth. What would happen if they miss a tooth? They're going to use the other side. If you keep chewing on one side, obviously there's going to be a formation of asymmetry. The muscles are going to form there. They're going to develop more. And these are the kind of patients that we see day in and day out. You could see them every day. When a patient comes to you with requiring a bridge, for example, if this patient came to you for a bridge on this left side, I'm sure 90% of us, because that's what I used to do, would provide the bridge on the very same occlusion, which is again creating this situation even worse. So we need to correct the entire jaw position, relax these muscles and bring them to the right position, and then provide the bite, provide the bridge. That's what we need to be doing. So struggling muscles are hypertonic, and these are the ones that lead to, so that with that girl, if that she was chewing on one side, you would see all the muscles developing there, and then those muscles are now going to end up as headaches and migraines and neck aches and shoulder aches. We should understand that most of these aches, TMJ disorders as they are known as, the craniofacial pain or even orofacial pain, uh, are 90% myogenic in nature. They are muscle origin. And that's what we deal with. These are all muscles. It's all one. It's not the face is separate, the head is separate, the ears is separate, the neck is separate. No, this is one unit. We need to be working on this entire unit, the head and neck area, which is why we were taught all of that in the first year anatomy. Remember? Well, this is the fact of the matter. First year, we learned the anatomy, physiology, dental materials, and we passed the exam somehow, even questioning why we even learning muscles of the neck, because we are just dentists, right? Well, second year, the same thing. You learn whatever the subjects are, and then you pass them somehow. Third year, same thing. You don't remember any of that. Fourth year, all those subjects, the 7 subjects, that's the only thing we remember for the rest of our lives. Why were we taught those subjects in the first and second and third year? You got to relearn all of those if you need to be a good dentist, or you're just helping people like me. Sorry, but it's a fact. So, muscles. Again, we would have heard about just these 4 muscles, right? Muscles of mastication. Well, that's just not all, because the entire skeletal system, the skeletal musculoskeletal system, the stomatognathic triad is supported by all of these muscles. You don't need to know all of them by heart per se, but you need to be aware that these muscles are also acting, and which is why these are all connected to each other with fascia. There is fascia. There's a huge fascia level. I'll be talking about that. There's huge fascia layer across your body. They are all connected. All the muscles are connected by that fascia. So anywhere there's a pull, the fascia is going to act. Simple. Ligaments. Again, the same thing. So I was talking about the fascia. I love talking about the fascia because there's something new that's come up. Um, I was aware about the frenal attachment of the tongue or even the lips, but right now it's come up like really huge. The past 4 years, there's a lot of research, and we've been doing a lot with the tongue ties that we see in all these patients. I even have colleagues. We have members in ICMO India who are consultants in the neonatal ward of hospitals. Uh, they're trying to correct the tongue ties even on those kids as soon as they're born. So most of our patients that I see right now, when they walk in with a deep bite for an orthodontic consult or even with pain, 90% of them have a tongue tie could be anterior, it could be posterior. And these are things that you keep learning. Earlier to that, I learned about cranial nerve screening. Why wasn't I looking at that? So you keep learning new things. It's all, again, think about it, it's all just about the bite. Okay. The nerves. Trigeminal nerve is known as the dentist nerve. It comprises 60% of all the neural tissue of the 12 cranial nerves. Think about that. Along with the spinal accessory and the auriculotemporal nerve, these are the three nerves that we're really involved with. Now, this is the fact. Neuromuscular disorder symptoms could be ascending, when a bad bite can be caused by other postural physiological factors, or descending, where a malocclusion can be cause of the other issues, like a foot pain or whatever. It all starts with the erect posture. We need to know what the erect posture is. The first point in the postural chain is the TMJ. And what controls the TMJ? It's our occlusion, right? So the TMJ, the cervical vertebrae, the shoulder joint, the hip joint, the knee joint, the ankle joint. That's how your posture should be. Anything off this is going to cause a compensation in the other parts. And that's how people end up with the wrong posture, postural pain. And that's where most of these athletes suffer. They have a wrong posture. Either they were born with it, or they were during development, they were mouth breathing, they had uh, tonsils, adenoids, anything that could stop the airway from functioning normally. So you can see in this how a short foot created all of these issues. A short foot over here created all of these issues. So that's what happens. For example, if your jaw, this is an example, if your jaw is shifted to this side, like that girl's was, to compensate for that, the head shifts. To compensate for that head shift, the shoulder droops. To compensate for that, the hip moves and then the foot pronates, and vice versa. So I keep talking about this patient we had in when I did my training in Italy. He had undergone 2 surgeries for his back pain when all his problem was a short foot and a bad bite. So we had to give him an orthotic on his foot and his bite. And he was fine after that. That's how important we dentists are. So with every change in mandibular position, there would be a change in cervical position and vice versa. So what came first, the egg or the chicken? I don't know, but I kind of believe in what do you say, evolution. So we still can't answer that question, can we? But I think it should be the egg, right? Okay. Anyway, but with regard to this, it's up to us to diagnose what came first, right? Which is why you need to have a team effort. We are closely in all our offices have a physiotherapist and, if possible, a chiropractor. We are in touch with an ENT. We are in touch with a psychiatrist and a pulmonologist to help with breathing. So cervical movements alter mandibular position. So when you flex your neck, what happens to the jaw? The jaw comes forward. When you extend your neck, the jaw goes backward. Simple. So this is where NMD gets its importance in sports dentistry. The C1 and the C2, okay, which is the atlas and the axis. The atlantoaxial joint, along with the atlanto-occipital joint, is the most important thing. But I'd give more importance to the AA joint, the atlantoaxial joint. Why? Because the plane of the atlantoaxial joint is, these are research papers, these are proven things, are in line with the occlusal plane. Believe it or not. So anything wrong with the occlusal plane, there is going to be a direct reaction on the neck. Most of our patients come to us with a forward head posture. Why? Because the airway is small, and that's an occlusal issue, right? This is something that you should be aware about. This is how a normal neck is. It's got a reverse C section. This is how the neck straightens up. Is known as a lordosis. Further straightening goes reverse C. This is the kyphosis. And with with the current use of mobile phones and your uh, iPads and the computers, is just making it worse. You keep going forward and forward and forward. So every inch forward, your head is weighing like almost 30 kilos extra, 20 kilos extra at least, every inch forward. So think about that. So it's either postural related or it is airway related. So posture is when you're working on a computer, you're not following the right posture, you end up slouching. And airway is when we see most of our patients, they almost all of them have an airway issue. So the airway is compressed. Airway means the space between the tongue, your oral structures, and the back wall of the pharynx. If it's really narrow, there's not enough oxygen going into the brain virtually tells the head to move forward so that the airway opens up. And then it's a vicious cycle. So we need to correct one after the other. So we are in touch with chiropractors and Yucca chiropractors to get the body line corrected, the posture corrected, because just our orthotic won't work alone. We shoot our bites after the physiotherapist works, like I'll show you in a couple of cases that we have here. The physical therapy, there's tonicity exercises, hip rotations, all our athletes go through these. And then there's Dr. Mariano Roccobado, whose course I'm undergoing right now with the Roccobado cervical distraction technique. We can also work on these patients' necks without the help of physiotherapists. We do these post TENS. You can see how the TENS unit is attached here. So, the right bite protocol for sports dentistry. The most important thing is diagnosis, right? We need to find out what exactly are the problems here. We do a radiology. Our diagnostic protocol is almost like an hour and a half. Our appointments are almost 2 hours long with each patient because we need to take extreme care to be precise and to provide the right bite. The final aim is to create a muscle balanced, physiological, bilaterally symmetrical myo trajectory. Like I said, if you have a habitual trajectory with the bite onto the other side, okay, that bite is wrong. That trajectory is wrong. You got to correct the trajectory. And a myo trajectory is when the muscles are more relaxed, okay, and they are more isotonic. They are more symmetrical in nature, the left and the right. More often than not, if this is the bite and this is the habitual trajectory, once we tense the patient with special TENS units, not the normal medical TENS units you buy outside, special TENS units that we have, they relax the muscles. Once they relax the muscles, everyone thinks once you relax muscles, the only thing that changes is the vertical. Absolute nonsense. We change the pitch, which is the vertical, as well as the yaw and the roll. How? Because it's the muscles that control all three dimensions. If the muscles are relaxed, then the jaw comes downward, forward with the yaw and the roll corrected. And now that is your new trajectory. And we need to find the bite on that trajectory. I know it's impossible to understand in this 40 minutes or 1 hour that I'm going to talk here, but this is what we teach at our courses. So if you're interested, uh, log into tmjindia.com and all the details are out there. So this is our sports NM protocol, TENS therapy, mandibular kinesiography. We provide the orthotic, then we correct the digital microocclusion, and we finish it off with a computerized postural balance. There are several bites that can be taken. The TENS bite, the phonetic bite, the CR, muscle facilitation test, dynamic decompression, K7 bite is what we do, the can bite, or even the simple anterior jig bite. Which bite is better? No one knows because there's no research that's been done yet because no one does everything, right? So we're planning to do one with ICMO. Let's see. But what we do is the K7 bite because we are more precise, we are more measuring. All the other bites, they don't measure much. With the K7, we measure more, so we are more sure about where the jaw has to be. Talking about being sure, I'd like to mention one point here with regard to the orthotics that we provide, the splints that we provide for a TMD patient that walks in. We have been taught over years at dental school that we need to provide a deprogramming splint. Only a deprogramming, so it could be flat, doesn't care. Why a deprogramming and not a reprogramming? So that's what neuromuscular does. Neuromuscular dentistry helps you provide that reprogramming bite, reprogramming orthotic. Why? Because we know exactly where that jaw has to be. The deprogramming doesn't. So we give it, wear it for a few months, pain will go, okay, you're fine till the next time. Right? But with reprogramming, we know where exactly the jaw has to come to. So we give that splint, it's reprogrammed, and we maintain it there with braces or full mouth reconstructions, depending on the patient's dental hygiene. I just wanted to mention that. Okay. So what we do is we tense the patient for 45 minutes. We check the EMGs till they're isotonic. Isotonic means since we measure the EMGs, we need those EMGs to be less than 2 microvolts. Microvolt is what we use for measuring the EMGs. Post tense. So when we are tensing, you can see here we tense not just the joint but also the neck. So what are we tensing? Whoopsie, kya ho gaya? Just went off. Okay. So what are we tensing? We are tensing the neck, which is the spinal accessory point. We are also tensing the joint area where you have the trigeminal and the more deeper facial nerve traveling through. So what these tense units do is it's not tensing the muscle directly, unlike the other medical.
I guess there is some network issue at Dr. Raj's end. So the team, backing team will try to reconnect with him. Let's see if he's on board. Yes, sir. Welcome back. There was some technical glitch, I think, that happened.
Am I clear now?
Yes, yes. You're very much clear, and we can listen. You're audible too. So you carry
Okay.
on.
Can I continue?
Yes, sir. Sure.
Oh, okay. So okay. So the tense unit is for the TMJ area and the cervical area. So the cervical area, the spinal accessory connects with the plexus behind and supplies all the capitis muscles and the splenius. So we have control over the entire neck and 90% of all the muscles of the head and neck area because of the trigeminal and the facial nerve. So that's how these tense units are very specific. Another important point with the tense unit is the pulsing is simultaneous on both sides. To you don't have any other tense unit in the world that provides together on both sides. Okay, and then the third point is very important because it maintains a 1.44 second time gap between the two pulsing, and that's important. And it's because a lot of research is all research. It's important because the axon and eosin fibers, they need to be at 60-degree angle. There's a lot of trigonometry there, but that's a fact. For proper resting length, it needs to be 1.44 seconds. So they have patented it, and only they can make that. So there you go. Any other tense unit is just temporary. Anyway, so once the tensing is done, the physiotherapist, it makes it easier for him to work on the entire body. So he corrects the postural and visceral attachments, uh, including the abdomen, the legs, the neck, the head, the whole body. Because as I told, the body posture is important. And then we measure the interincisal width in PRP. PRP is the rest position, the physiologic rest position. So you have rest position, which is habitual, and then you have physiologic rest position, which is post tense. Once we measure that gap, we cut out a piece of, I use impression compound because it's cheap and easily available. And then we make sure that it's the same thickness as an interincisal width. And we mark the PRP position. And then from that PRP position, we mark grooves in forward and behind. And we then check with each groove the mandibular jaw position, and we confirm the muscle testing with, we confirm the strength where the jaw has to be with muscle facilitation tests. You have to know that, I don't know if you know about this. Uh, as an example, when you do arm wrestling with your friend, most of your energy goes into your clenching. Clenching in there. All you have to do is get the jaw to the right place, and then all that energy would be going to where it has to go, to your arms. This is all about ATP and energy delivery, and this is how neuromuscular works. It opens up the airway for one thing, it gets your position much better, and it also gets your energy to the right places. So we shoot the bite there, and we make sure that the frenal alignment is aligned, and then we make sure, confirm whether the interincisal width is confirmed. And then we send it to the lab. The lab is Right Bite Dudent Neuromuscular Orthodontic Lab, and they create this Right Bite Sports Guard, which we provide to the patient. So for this patient, like I said, there are two protocols that we follow. There's a TENS protocol, and then there's a K7 protocol. The TENS protocol is only like 70% as precise, but the K7 protocol is 99% precise because we know where exactly to go to. But this is because we are in India, I had to make sure that all socioeconomic status is, that we call, we pay attention to all of them. And this is what the RBS Guard looks like. We can get in different colors of our choice. And then once the orthotic is in the mouth, we apply the TENS and T-scan adjustments with MAT scan posture analysis. So we'll talk about a case. So this is a patient that came to us. She is a female badminton player, age 17. She did not come to us with, for a sports guard. She came to us. I didn't even know that she was a badminton player. I mean, she played badminton. That's all she said. She had headaches and neck aches. She came to us for those issues. She had these sleep issues. She's always injury prone. That's one thing that I understood. And she kept getting locked jaws, so difficulty in mouth opening, pain while chewing. One of the same old cases. So you can see how her face is rotated, shifted to one side, how her shoulder is drooping, how her arms are overturned. Arms overturned when the head posture comes forward. That's mainly an airway problem. So these are the symptoms: intermittent lockjaw, headaches, neck aches, extremities tingling. That's because of cervical issue. So if there is an extremities tingling, that means there is a cervical problem as well. Night clenching, which is a sleep disorder. Again, when you talk about night clenching and sleep disorder, I've seen a lot of dentists provide mouth guards, night guards to patients which are just simple S6 retainers to patients. What you do with those mouth guards, those night guards, what they actually do is just protect the teeth from further deterioration because of the clenching. You're not stopping the clenching. So people think the main cause for clenching is a psychological problem. Absolutely not. 95% of all sleep issues are of obstructive sleep apnea and bruxism are caused due to an airway issue, and it's not caused due to a psychological issue. 95. Remaining 5%, yes, psychological. So all of these things are we see in the patient's problems. We do the radiology. What do we see? We see impacted teeth. There's no space, so we need to get them off. Not necessarily, actually. We see a deviated nasal septum, obviously because she has a high palate. Why did the high palate form? Now I know that it could be a tongue tie, which I didn't know back then. So when she developed, the tongue was not on the palate, so the palate developed upwards instead of sideways. So there was no expansion. If the palate develops upwards, what's connected to the palate? The septum. The septum bends. Common sense. Anyone with a DNS, they keep doing these surgeries, and what do they end up with? A relapse. Why? Because the septum, because the palate is not still solved. Right now, we send our DNS patients to the ENT only post expansion, because otherwise it's going to relapse. And this is very important. What do you see there? The mesenteric notch. Why is that clenching? I mean, why is that happening? Why is it getting deeper and deeper? Because of the clenching. And you can see how the condyle is not coming forward enough. And this is something that we've been doing for every patient. So this is part of a protocol. We do a home sleep test. That's why we need the pulmonologist in hand or an ENT. You can see how the AHI. So what we look at is the AHI levels, which is really high, the RDI, the desaturation. So every time a patient desaturates during sleep, wherein the tongue goes back. So most of these patients have a deep bite, the jaw would be positioned backwards. What happens? The airway gets compressed. When the airway gets compressed, not enough oxygen going in. The body recognizes this, it tells the tongue go forward, and it bam. As it goes forward, the teeth clench and the patient's sleep is broken. And this is what happens with desaturation. So every time you see a desaturation, you should see a clench. Again, so this is not fully confirmed. There's just a few research papers. So right now, what we depend upon is something known as a GEMPRO Bruck study. So with that equipment, what happens is we record the desaturations and the clenching and the level of the clenching, how powerfully they are clenching. So without that, we could never know if you're treating the clenching, if you have successfully treated the clenching or not. Just added info. So what was the treatment protocol for this patient? The first phase was to make sure that the pains and all those difficulties go away. She's back to a normal human being. So we give her a TMJ acrylic orthotic, and we give her obstructive sleep apnea oral appliance. Second phase would be maintain that jaw position that we got with the TMJ-AO with neuromuscular orthodontics and controlled arch. And the third phase, if the patient was still interested, would be the RBS Guard. So these are the scans that we procure with the K7, the more precise equipment that we normally regularly use nowadays. So you can see this is pre-tense. The mouth opening isn't good enough. And the muscles, you can see they're all pretty high. So these are the temporalis, the masseters, the sternocleidomastoids, and the digastrics. These are the four sets of muscles that we measure. And they all need to be below 2 microvolts. And most of them are not. This is before tensing. So see what happens after tensing. They all come below 1. So right now, at this position, we should shoot the bite because the muscles are relaxed. The jaw would obviously be from here, from this habitual rest position to a more physiological rest position. And post tense, well, not much of an improvement, but good enough. It's going to improve. You cannot expect the mouth opening to improve to 35 millimeters or, even by 50% on day 1 of tensing. You need the orthotic to reprogram those muscles to function better. And we use the scan 5. So if this is the centric, then this is the myocentric. So it's downwards and forwards. We provide the patient with the orthotic. The orthotic is worn 24 hours. And we check the patient every month, every 2 months. We do the corrections. So we use Dr. How many of you guys have heard of DTR, right? We use that protocol on these orthotics. We check for disclusions. Robert Kirstein, I don't know if you heard of him. Pretty famous guy with DTR. So we incorporate the T-scan there on the orthotic. And once we find that all the EMGs and everything are fine, we go ahead with second phase orthodontics. So how do we do that? We cut out the posterior side of the orthotic and allow for supra eruption. We do not bond the sevens because I'll show you in the next figure why. Because we want them to physiologically supra erupt so that there is more balance. So that is more stable. Okay. So once the posterior supra eruption occlusion has happened, we remove the anterior part and we wire the anterior. And then once that is also done, we then do controlled arch. So there's Dr. Steve Gallela, who has come up with the trademark controlled arch technique, amazing technique. We now give the patient option whether they want to do Damon insignia. So right now we do a lot of Damon insignia because they are customized brackets for the patient and they help in beautiful. We know where exactly the teeth have to be even before you start. So and the patient can see it also. It's much like Invisalign but with brackets. Invisalign is a little difficult to incorporate with neuromuscular orthodontics because we aim because we need a lot of supra eruption, which clear aligners can't help with, not as yet. So that's what we do. There is a specific technique that we incorporate. You'll have to learn the basics, but there is a FRLA, a lingual arch that helps with expansion and retraction together. Amazing technique, and it helps all our patients. And then once this is done, so by the time she wore her first phase appliance in like the first couple of months, the second month or the third month, she could see a tremendous improvement in her posture. You can see the difference, how her face is more straight, how her posture is more erect, how her head has come back. So, it's not forward anymore. How her sleep improved, AHI, the apnea hypopnea index by which everyone goes by, from 65 events, it came all the way down to 5. Okay, so I've got 10 minutes. Snoring reduced from 3,000 events to just 97. The RDI index, again, something to do with like AHI, came all the way down from 68 to 9. So all of this helped with just phase one. So once she understood the phase one part of it, if phase one could help her with so much improvement, and all of this also helped her play better, her game improved. And that's when she came to me and she said, look, doc, I'm playing much better. And she got selected into the team, A team or whatever. And then, okay, so then we have something known as a mouth guard. So we went ahead and we got the bite done with the post dynamic decompression and K7 test. We got a bite done and we found that's where her jaw wants to be. We made the bite for that. We gave her that orthotic. Now, once the orthotic is in the patient's mouth, there would be a change in posture. So before the orthotic was put in, the bite was at 54 and 46. Okay, and with a different postural change as well in where the feet are landing. You can see this 23 psi here and 19 psi here. Once the orthotic was given, and before we did the corrections, the postural change did not improve, but the pressure changes happened. It improved to 21 to 19. And then we put her on the TENS and the T-scan, and you can see how with every jump in the TENS, you can see with every jump in the TENS, there is more bite on posteriors as well as in the anteriors. So that means it needs to be an anterior correction. Sorry. Okay. And when we check the T-scan again, you can see how there is a lot of bite on the anterior side that was reduced again. And after reduction, you can now see how the bite has improved. There's still some anterior reductions to be done. And once we did that, we checked the MAT scan posture again. You can see how it flipped from 21 to 19. It flipped 19 to 21. Okay, the other way. But this improved for 52 to 48. Okay, post T-scan correction. Now the patient has to wear that orthotic and get used to it, right? So we need to give some time to the patient, not the patient anymore, to the athlete. And guess what? She got into the state team. She got into the national team. She's suddenly all on TV with ads and wonderful stuff happening to her. And then the final corrections that were done recently, not recently actually, before the lockdown, maybe actually much before, I think last July. So I had done this presentation in Moscow when we were there for the ICMO International Conference with 20 of us. It was a great gathering we had there. So we have these conferences once in a year, either international or in the US, and then we do our conferences as well. So if you want to learn more about this, the first thing to do is be a part of ICMO. I'll be talking about that again. So this is what we do. We incorporate all the technology out there to make it a part of our life and help patients' lives as well. So you can now see how well it has improved 5149. Getting better than this is virtually impossible because no human being is that perfect. Right? So think physiologically, not just dental. Think muscle, think joints, think teeth. Okay? There are a myriad of other NM disorders that a dentist can treat, not just fillings. Okay, you can treat TMD, you can treat sleep apnea, CCMD. I call it CCMD nowadays, not just TMD. 50% or maybe even more than that, 80% of my patients, I could say, they don't even have TMD. They have pain, craniofacial pain. They've been to dozens of doctors and they just come back. They have medicines, this and that, but they're still in pain. Why? Because the jaw is still not in the right place. And no TMJ disorders. So what then could be the problem? Muscles. It's myogenic. Get the neck straight, get the jaw aligned, give them the orthotic, voila, pain gone. And we're doing this day in and day out for all those symptoms that you see written there. All these. Okay. I've had wonderful cases with cervical torticollis and palatal myoclonus. I just don't have the time to present that here, but these are cases that we do almost every day. So to conclude, in short, you got to de-learn, not just deprogram your facial muscles. You got to de-learn and relearn the same things again, because you got to give more importance to your pre-dental subjects, mainly anatomy, physiology, and biochemistry. Ultimately important. You need to know why all this is happening. It's that curiosity within me that got me to what I am doing right now. And I'm really proud of this because I'm really proud of where I am right now. To be able to talk to medical doctors about the kinds of ailments that we help with, to be doing something that no one else is doing. It's just an amazing feeling. I'm sure all my fellow ICMO India members will be feeling the same thing. They've all come through the ranks. They've all had their hard, perseverance, same stories, because no one believes you, right? No one believes. When I came all the way in 2005, no one believed me. Perseverance. It's all about that. And keep learning. You just don't stop learning. I'm still learning. You keep learning, right? The main take home point is we are not just tooth doctors. Stop thinking that. Okay? Dhanyawad, gracias, pasibo, shukran, obrigado, grazie, merci beaucoup. Thank you. Any doubts, you can come to icmoindia.com or tmgindia.com. My email ID is there. You can shoot any doubts. And that's about it. Dr. Pallavi, Dr. Roxon, I'm done.
Thank you so much, sir. Thanks a lot. And this was an
I was given an hour's time, and I believe I finished in an hour.
it was an insightful session, and I could actually be here and listen to it more and more, because it's something like I need to do my dentistry again, it gave me that kind of feeling. But yes, it's
Well
so
said.
true that we have bought this to ourselves. When people call us tooth dentists, that is because when we actually make the patient sit, we actually look at the tooth only, because
Yep.
anything else will be like, you might be thinking too much, you might be taking too much stress,
Yep.
I have done
Mind
the
yourself with
selection.
stress.
Right. And just one bite can lead to the wrong posture and lead to the trembling of hands and everything. I have never seen that, to be honest. Like, I've
You just
never
need to
even
be
in
at
the
our.
moment.
You just need to be at our any of our centers for one day. You see the kind of patients that
I
come
guess
in.
I'm going to visit at Delhi Center soon.
Yeah,
And
cool.
coming to questions, there are a few questions. First of
Okay,
all, amazing work, very informative session. I think
thank
people
you.
are inspired to know more about NMD and to more about this system as a whole. There have been some questions where people are asking from where to learn more. Like, is there any course that we can do in India? How to learn more?
Well, the first thing is, come to our, what do we say, our website, tmjindia.com. We do a lot of courses with a lot of our ICMO India members. We do these courses together.
Okay.
That once you start this, so this course is very comprehensive. It's on patients. It goes from day one with patients. Then if you follow it up with and you end, you know, 3 modules of 4 days each, hands-on fellowship. You end up with a fellowship of from ICMO,
Oh,
basically.
okay.
Yeah.
That's nice.
So it's a very
So there
comprehensive
is
course.
answer to that question, that you can learn more. All you need to do is you have to follow Dr. Raj wherever he is, and then
No,
get
no,
all.
no, that's okay. tmjindia.com. That's fine.
Okay, tmdindia.com. Okay,
tmjindia.com.
tmjindia.com. Yes. And then another question, sir, is bruxism in children. How can we correct it?
Okay, so that's beyond the subject that I talked about.
Right,
But
right.
great, I'd love to talk about this. So
Okay.
I have an entire YouTube video. If you check my YouTube channel, Dr. Rajesh Raveendranathan, I have an entire webinar that I talked about bruxism. I'll try to concise it within 30 seconds. So the first thing, what is bruxism? Okay, people again, like you just said, bruxism. People think it's more of a psychosocial disorder. Absolute nonsense. Bruxism is 95% of the time an airway disorder, especially in children. If the kid has some sort of an airway disorder, if the kid is mouth breathing, the bruxism chances of bruxism increases. We need to not just give the kid a mouth guard. We need to make sure that that airway is more clear up, especially with kids. Since you talk about kids, ADHD. You've all heard of ADHD. It's the attention deficit disorder.
Right.
So, but ADHD is basically sleep apnea, obstructive sleep apnea. It's just another name for obstructive sleep apnea, I would say. Earlier, they used to give drugs, even in the US, they used to give drugs, Ritalin, and other stuff, just to make sure that the patient is functional. Now, the first line of treatment is a simple adenotonsillectomy. You get them off, the patient is back to normal, the kid is studious again, he has his attention, and he stops bruxing more than anything else. So the brux guard or the mouth guard or the night guard that we provide to the patient to stop the bruxing is not stopping the bruxing. It just is delaying the inevitable. Constant bruxing will end up with further TMJ disorders. So that needs to be kept in mind. So change the way you think, and understand what bruxing is more than just psychological disorder.
Right. So that is like a question from my side, because I had this one of these kind of patients.
Okay.
It was a
I
close
have
relative.
an entire webinar online on YouTube on my channel. So if
Okay.
you're
Okay.
interested,
So
you
I'll
can
go.
go on. Yep.
Yeah. There's one question. What is CCMD?
Huh. Okay. So you have TMD. So we have patients coming into our office telling, "Oh, doc, I've got TMJ." Well, duh, you have TMJ. What you're suffering from is TMD. So it's all about nomenclature. Temporomandibular joint disorders are TMD. And I just mentioned in my lecture as well, it's not just TMD that we are dealing with. Right now, more experience you have, the more you learn about these things. Patients come to us with huge craniofacial pain. You check their X-rays, you check their CBCTs, you check their MRIs, you do palpations. They have nothing wrong with their TMJs. So what? You don't treat them? No, they're still your patients. Why? Because their muscles, the muscles that the jaw is connected by, they are in pain.
Right.
So you got to treat them. So these patients are not TMD patients. I call them CCMD, which is cranial cervical mandibular disorder. It's just another term. We don't
Right.
have to remember these terms. It's all about craniofacial pain, and you don't need to be diagnosing us. So, like again, every doctor and every patient, they want to be coming just to that one name. So what is it? Finally, what is it? No, it doesn't have to be finally one thing. The more important thing is to diagnose what all has caused that problem. There's
Exactly.
always a multitude, it's always multifactorial. Find out all those causes, remove all those causes, and then get it treated. That's why you need a comprehensive diagnostic protocol.
Treatment plan. Okay, sir. Listeners, can you enlighten about K7 bite?
Ha. So when we use the K7, it's basically a computer scanner. We have a magnet on the lower teeth, and then we use a sensor array that lies over the head, and then that detects where the jaw moves in 3 dimensions. So what we see on the computer screen is small squares, and each of the squares is 1 millimeter square in area. So that means the jaw position can be anywhere within a 1 millimeter square area. Okay. If you do not use the K7, you are now going to assume where within that 1 millimeter square the jaw has to be. And that assumption, if it's off by even half of a square of a millimeter, then the patient is back in pain, which is why we use the K7. So K7 is produced by a company called Myotronics, which is what I use. There's another company called BioResearch. There are other companies as well, BioCat, there's Biotech. There's several other companies as well out there that produces these equipments. We even have Sirona with their SciCat that comes along with their CBCT units. So there are several equipments out there that can help you. They are known as kinesiology devices. So because kinesiology is all about movement, and these give you actual tracings and help you with better, precise bites.
So that was Dr. Vidya Sagar's question. I hope you got your answer, Doc. The last question for the session, sir.
Oh,
Based.
one second, Dr. Vidya. I am sure that 1 minute description of a K7 is not going to help you. Uh, we have, I have other lectures as well on my YouTube channel, so if you can go there, you might hear much more about it. You can understand more about it. If you still have doubts, shoot me a mail. My mail ID is on the website. So
On the app too. Yes, sir's website on the email ID is mentioned on the app too. So he himself has told shoot any of the questions, queries you have, so you can directly put across. Last question for the session, sir. What basic things that we can take care while doing the simple restoration to avoid getting into these?
very good point. So, what do we normally tell our patients, right? When we give a filling or a bridge, we give it to the normal bite, right? And then we tell, we reduce something and all, and we tell, okay, adjust muddy.
Right, right.
Yeah. So that adjust karo, that Indian attitude of adjust karo
एक दो
is
दिन
now,
में ठीक हो
I,
जाएगा.
I should not be telling this, but I hope it's only dentists here because 90% of my patients are iatrogenic, period.
True, true, true.
Yeah. So they're either bad prosto cases, they are bad ortho cases, they are bad fillings. It's just so that that patient I was talking about with the jaw moved to the right a lot was because there was a filling on the left. It's not a missing tooth. There was a filling on the left that made her move to that side. All I had to do was reduce that filling, and she's back to normal. No more headaches, no more migraines. She had migraines for like 10, 15 years just because of that filling. The ENT couldn't find it out. The neurologist couldn't find it out. She was on medicines for 15 years. Think about this. Okay. And
Exactly.
all I did was use the T scan, find out the high point, reduce it, check the muscles, get the right jaw position. Gave her an orthotic for 2, 3 months till her muscles relaxed. She's fine.
Right.
So what you have to do is, like if you're giving a restoration like a filling or a bridge, what you have to do is make sure you check your disclusions as well. Again, another important point is we use articulating papers. What even my name has a company, I think Rajesh or Priya or Vijay. I've seen all of these articulating papers. They're all 200 micron, 150 microns. No, they don't work. Our teeth can has a proprioceptive levels of up to 8 to 10 microns. The thickness of a hair, I don't have it, but up to the thickness of a hair, the teeth can propriocepte. So if you're going to put in a 200 micron thick paper, you think it's going to help you, the patient? No. Use 20 microns, 12, okay, at least 20 microns, forget 12 and 8, at least 20 micron papers, and it's available. It's available in the market. You get Bosch, you have Capg, you have another Italian company. So there are lots of them out there where you can, and it costs like maybe 5 rupees more. Use it. Check the bite. Check both sides disclusion, canine disclusions, anterior disclusion. We learned all of this, but we do not
We do
use
not practice, implement.
it's just another maybe 90 seconds more of work that you have to do. It's just 90 seconds, but
Right.
you can help make sure that
Save
the
it.
patient doesn't get into pain. That's all.
Right. Could Dr. Rahil has asked a question. Any normal value or a standard value that has been set for occlusion, or every patient has different calibration?
Absolutely. You every patient has, because the teeth are in different positions. The maxilla, the mandible, the jaw position is different. The jaw shape is different. There could be a torque in the jaw. The whole head, there could be a cervical problem. So when you talk about occlusion, I would rather go with a neuromuscular occlusion because that's what finally has to decide where the jaw has to be in terms with each other. When you do orthodontic cases, when we finish ortho cases, we try to finish them in class 1, right? I don't believe in that because it doesn't matter what class it is in. Finally, what we need is the jaw indenting with each other in proper disclusion with the muscles in isotonic position. That's what's more important, which is why we give a lot of importance to the neuromuscular bite more than the myocentric bite, more than the centric bite. So the myocentric bite is a muscle-based centric bite, which is more often than not uh, downward and forward when compared to the centric. Now, normal human being, a healthy human being, I'm not saying I am, but for example, me, because I've checked mine every time. I mean, I've checked it like a couple of times. So my centric and myocentric is the same. So I've tried the sports appliance on myself. It didn't work. Why? Because my jaw is in the perfect position.
It's in perfect position.
It's in perfect position. I mean, I'm not saying I'm perfect, but it happened to be in perfect position. So this is not something that's going to help everyone. If there are 100 people out there, if there are 100 athletes out there, at least 20 to 30% would need them. So if it's a team game, it's very important that if 30% of those guys are not functioning well,
Right.
the whole team is going to go to not. So that's the difference.
And actually,
So if you talk about a bite, it has to be in neuromuscular. Sorry, yeah.
okay. And actually, that pain can be very bad. Well, I myself have experienced it once because I got one filling done. So it can actually, it can create a lot of problems.
Well,
So, okay,
most of our patients, the number one symptom is migraine.
right.
So, and how is migraine diagnosed? This is how migraines are diagnosed. You have headaches, you give them medicines, okay, they don't work. Give them another set of medicines, oh, they don't work too. So you have migraine. No, that's not migraine. That's not how you diagnose migraine, at least. Uh, ENTs know that 80 to 90% of the time migraine is caused due to TMD, but they do not know who to refer to,
Who to
because
refer?
even we have been advised, and what we have been taught is to refer to a surgeon,
Right.
right? But even the surgeons don't know. Surgeons would more often than not give a night guard, or even do a myotomy, which is even more dangerous. When
Exactly.
actually you can restore the bite and make sure that the migraine is off. That's the first thing. So when a patient comes to me and tells me the TMJ, I said, don't worry, that migraine is going to go. That's what you need to keep in mind.
A very interesting question. How you develop interest in it? I thought you already
Oh, that's a long story.
long story.
But basically, it was Dr. Fabio Savastano. I don't know if most of you would have heard of Dr. Sibi Xavier. He used to do these conferences in Bangalore, IDRR. So he once brought in Fabio, and I happened to hear his lecture. I joined his course. I followed him all the way back to Italy. This is way back in 2007. And there were other guys who were in my batch, but they just did the basic stuff and didn't follow up. I kept following up. Like I said, I've got a very curious mind. I want to keep finding out why, because every problem should have an answer. So I'm just looking for that answer. And I think the biggest break was me doing my fellowship in sleep medicine in Tufts University in 2009. And that really changed my whole outlook towards pain and how it needs to be treated. So I incorporated what I learned with Fabio and what I learned in different conferences and from Tufts. And I've made a protocol right now, and that's the protocol. That protocol is known as the right bite protocol. It's copyrighted, so you've got to say what you've studied and what you practice. But this is what we teach at our courses. The right
And
bite.
and now many people are going to follow you after this because it's such.
What we've actually made it much easier. So when I was doing this, there was no one to guide me.
Yes.
Right now, there are a lot of people who have done this, and they're all there to help you. ICMO India, another website that you could hit, icmoindia.com. You'll see all our members out there.
Yes. So I think that was like a fabulous session, and I am taking so much from it. I am going to visit your YouTube channel also, because
Oh, thank you.
now that patient of mine is stuck in my head. Like what I can do with the patient.
Yeah. There's always that one patient that you keep remembering.
Yes.
Yeah, I know. Cool.
Okay.
Thank you, Dr. Pallavi. Thank you, Dr. Roxon,
Thank you
again.
so much. Thank you so much, sir. It was lovely having you, and all the best for future courses and everything. And I hope to see you in the center someday.
Yep. Hope so too. Cheers. Thank you.
Yes, sir. Thank you so much. Thank you. So that was डॉक्टर राज. नाम तो सुना ही होगा, अब तो सबने सुन लिया है डॉक्टर राज का नाम, and everybody knows about him right now. So yes, there's so much to learn, and Dr. Raj's journey reminds me of a very, as I told you that I'm a poet also, so I read also shairi, Hindi shairi. So there's a famous saying that of Majroo Sultanpuri, हम अकेले ही चले थे जानी बेमंजिल मगर लोग साथ आते गए और कारवां बढ़ता गया. So he started on his own, and then now there are many people. He has formed a team, which is in itself a very big thing. So congratulations to Dr. Raj for that. And thank you for asking so many interesting questions. Thank you for taking interest in this. And I think the session is done. And now some pointers for you guys. First of all, what I am taking home from this session is that I will stop looking just into the root canals and just into the tooth. There's so many things associated, and we need to work on that, especially occlusion part. So I'm going to search where those articulating papers are available. I'm going to order them. Other than that, yes, download the app if you haven't downloaded still, because without app, you don't get registered, you don't get your certificate, and you don't get your CD points. So do download the app. And also the competition that I mentioned, the lucky draw competition, Nova Lace, there are chances that you might win this Nova Lace laser therapy. therapy laser machine, and it costs a lot, guys. It costs a lot. So if you are lucky enough, you will win this. But there are some rules, and rules are that you have to join DRDCA FB group. You have to take part in one of the competitions, cultural competitions. The last date is 7th or 10th of November, the details of which are on DRDCA FB page as well as app. Download the app, register yourself, be active, ask questions, whatever silliest question also, if it comes into your mind, no, just ask it. And in the end of the day, when you're done with, share it with your friends, tag your friends, tell them to join. And once you're done with this, just take the screenshot and send it to us at drdca2020@gmail.com. Any queries, we are always available. DRDCA FB page is there. You can directly put across a message. Email ID, you can directly contact me. On FB, I am as Dr. Pallavi Mahajan. On Instagram, I am as Pal Poetry. So yeah, that side is there on Instagram. So feel free to connect with us. And next session is on Thursday. As I said, scientific sessions are scheduled for Thursdays, Saturdays, and Sundays. Next session is Thursday at 7:30 p.m. So once you are done with all your regular course, you can come over there and listen to Dr. Davis Thomas from USA and Dr. Sonal Yerpure from India, Mumbai, India, joining us and speaking about orofacial pain. So that is also something that I'm looking forward to, so many interesting topics. So keep coming, keep learning, keep increasing your knowledge, and yes, do download the app. See you guys. See you on Thursday at 7:30 p.m. Bye-bye.
My beautiful journey in this science started as early as 2006. I remember I was treating a 40-day-old baby and I had to take a laser unit on rent for 350 rupees from an ophthalmologist in my small town. It is that day that I realized that majority of the Indian dentists do not know how to use a laser, primarily because they cannot own one, they cannot afford one. I find Ratan Tata's work and life so very inspiring. He was the one who made us believe that as Indians we can do great on the international scene. He was the one who made me believe that poverty is not a handicap, but a poor mindset definitely is. He was the one who made the dream of every Indian to own a car possible. Similarly, Novolace, which was actually conceptualized and born as early as 2006, wants to make laser dentistry affordable to every Indian dentist. So with Novolace, we can proudly say that laser dentistry is no longer expensive, but the ignorance about its possibilities and what it can do for majority of the doctors and dentists who use it, and for the majority of the patients on whom it will be used, that we are trying to reduce the cost of that ignorance and make it very affordable. People call me an entrepreneur, people call me a laserpreneur, but I want to call myself a peoplepreneur because I work for the people. Novolace as a brand is different because we strive to make a difference to the lives of all the people who touch our products. We want to alleviate and ameliorate the pain and sufferings of millions of Indian patients. That is possible only when majority of our dentists get to own a laser, get to work with a laser. Our USP lies in the fact that today every Indian dentist can own a laser for as little as a lakh of rupees, even less than a lakh of rupees. So the concept behind Novolace is Indian, the design behind Novolace is Indian, but the execution is happening in a German console. So that makes it India's first truly international laser. Post-COVID-19, a lot of my friends, fellow colleagues, brothers and sisters in the dental fraternity are worried about their future. They are insecure. They are not sure as to what's in store for us. Well, this is my 16th year in this profession, and let me share something very interesting. The number one reason that kills dental careers is not the lack of degrees, experience, or the lack of patience. It is the lack of exclusivity. With laser dentistry, you can get that exclusive touch to your practice. With Novolace, you can think beyond the root canals and the crowns. You can think beyond the oral cavity and the head and neck. This is your best chance to be a laserpreneur. COVID-19 is neither the first pandemic that we are facing, nor will it be the last. So my Guru Mantra for all of you for the day is that uncertainty is the new certainty. Let's stop complaining, let's upskill, let's evolve, let's conquer. Jai Hind.